My topic today is on nutrition in critical illness, an update to convince you that if you look at the evidence available now, some of the myths that have prevented clinicians from using optimal nutrition therapy in critical illness can be forgotten. I'm going to present to you various myths and references for the evidence to show that those are just myths. Now, an obese patient can also be malnourished, and it is a myth to think that an obese patient cannot be sarcopenic. And very often, the obese patient is the patient who is neglected because the clinician forgets the fact that you don't have to be skin and bones to be malnourished. The obese patient may have disease-related malnutrition. And many patients don't know that pre-morbid weight, obtaining accurate weight is also not possible in an ICU patient. Fluctuations in weight occur because of fluid imbalance, and disease-related malnutrition is often missed and not captured in obese patients. And that leads to another important myth that exists, that we need to measure serum albumin, prealbumin, and transferrin levels. It has been shown in various guidelines that the traditional visceral protein levels are absolutely useless. It is true that low levels are markers of stress response and inflammation, but not malnutrition per se. Low levels highlight mortality and morbidity risk, but not to diagnose malnutrition. But more important, normal levels of visceral proteins do not rule out malnutrition. Serum albumin levels neither has a positive predictive value nor a negative predictive value of linking that with a diagnosis of malnutrition. If you want to pick up inflammation, use other tests such as C-reactive protein, leukocytosis, or a high glucose level, but not albumin level. And lots of money gets wasted to keep on harping on serum albumin levels. To the point that recently a paper was published by ASPEN, the American Society of Peripheral Nutrition, a position paper indicating that serum albumin and prealbumin should not be used as proxy measures of total body protein or total body mass, should not be used as nutrition markers. And a nice diagram shows that it is true that inflammation affects albumin and prealbumin level, but it is not for making a diagnosis of malnutrition. And therefore, I would strongly urge the audience to stop using this to diagnose malnutrition. We go to a few other myths. The gastric residual volume, where the residual volume in the stomach is checked quite often. This practice has been given up over a decade ago. There is no relation to aspiration pneumonitis, pneumonia, ventilator-free days, organ failure, or mortality. And the studies have shown that there is no need to measure it too. But it is very difficult to avoid it completely. When you have a known diagnosis of diabetic or uremic gastroparesis or delayed gastric emptying because of medications or GI reflux, or in the prone position that's very common in this COVID crisis, then you may measure gastric residual volume. And preemptive doses of prokinetic agents such as metoclopramide, dosages 5 to 10 milligrams every 8 hours, could also be used, but not routinely used. Retrospective analysis of 60 plus adult patients in a community hospital, critically ill patients, where elimination of gastric residual volume measurement had absolutely no effect on the patient, and a greater percentage of prescribed daily requirements were met. In terms of adverse effects, emesis, diarrhea, glucohomeostasis, there was no effect, no adverse effect at all. And these are new references from just last year. So the truth is, enteral feeding can be safely provided in patients with a high gastric residual volume of up to 500 cc's, if at all you're going to measure it. And GRV measurements should not be used as a routine care to monitor ICU patients on enteral feeding. Another problem is the passage of bowel sounds, thinking that you need bowel sounds and passage of flatus. Even now, physicians keep insisting on passage of flatus or bowel sounds before enteral feeding is started. Nothing could be further from the truth. The 2016 guidelines reiterated the earlier guidelines, saying that overt signs of contractility are not required for initiation of enteral feeding. We're not saying that it means a huge meal. It just means enteral feeding, 500 or 1000 cc's of enteral feeding a day, either through a tube or orally. You do not need passage of flatus or bowel sounds to initiate enteral feeding. Self-respecting physicians in intensive care don't carry a stethoscope to listen for bowel sounds to make a decision on feeding. So the truth is, you do not need bowel sounds. Another myth that we have a problem, especially with surgeons, is that enteral feeding should not be delayed in patients with recent GI anastomosis. Now, if I take a bottle of ink and put it into the sea, the color of the sea is not going to change. Likewise, in the small bowel, you have almost about 5 to 6 liters of fluid. And into that, if you add a small amount of enteral feeding, nothing is going to happen. No adverse effects will ever happen. In fact, there are less anastomotic leaks and fistulas in patients who receive early enteral feeding. This has been shown over 20 years ago. And even now, unfortunately, there are surgeons who believe that enteral feeding has been delayed because of GI anastomosis. In our hospital, we have patients with pancreatic surgery and GI anastomosis who are given a liquid diet. It is surprising that colorectal surgeons feed the patients early, even on the first post-op day, liquid diet. If the rectum can withstand stool, why cannot the upper GI tract withstand a small amount of enteral feeding, which is actually diluted by the saliva and the gastric secretions and the bile? So the truth is, enteral feeding should not be delayed in patients with recent GI anastomosis supported by recent guidelines, and anastomosis heal better with early feeding. The 2016 guidelines also state that we suggest that upon advancing diet postoperatively, patients be allowed solid meal as tolerated. Clear liquids are not always required as a first meal. And here's a paper that I published about the non-palatable special oral diets that are given to postoperative patients, like giving low-fat diet for post-cardiac surgery patients when you want them to eat more. No ill effects are seen from excess sodium in its relationship with blood pressure, or a cholesterol-rich diet, or even caffeine with arrhythmias, heart rate abnormalities in the immediate post-operative period. They may be useful for the community, for long-term care, non-sick patients, but not for the intensive care unit patients. So when you have a post-op patients who require a diet, let the diet consist of whatever the patient desires. What about enteral feeding with hypotension? Well, earlier we were more cautious, but now we know that if the blood pressure, the mean arterial blood pressure is more than 50 millimeters mercury, it is safe to use enteral feeding. Now, when the catecholamine agents, which are listed on the slide, are initiated to improve the blood pressure and the doses are going up, then we should stop enteral feeding. When you have a patient with hypotension, which is stable, enteral feeding can be started at slow rates, and you check the serum lactate level periodically. And also, this may be one condition where you may check the gastric residual volume, because it may be a surrogate marker of intolerance to more distal feeding. Another myth that exists is enteral feeding cannot be used with an open abdomen. Now, here is an abdomen that is open. Very often in trauma and in sepsis, the abdomen is kept open. Such patients always got parenteral nutrition in days gone by, but absolutely safe to use enteral feeding with open abdomen. Intrajejunal tube is preferred, but not always needed. Outcomes are improved as shown in these various publications. And it is possible even with gut edema, negative pressure wound dressings. But one thing we need to do is you have to give about 15 to 30 grams of protein per liter of exudate that is lost from the open abdomen. Enteral feeding within 1 to 2 days is safe, even with patients with open abdomen, provided there's no bowel injury, as in any other patient. In pancreatitis, early we used to always give parenteral nutrition, keep them nil by mouth. But this international consensus committee, consisting of 10 societies from various parts of the world, clearly shows that a patient-centric approach is used. Oral intake of liquids, solids, or even oral nutrition supplements can be given depending on the patient's wish and comfort. Now, if that is not possible, intragastric feeding, preferably continuous. If that is not possible, intrajejunal. And you can use regular polymeric formulas. You do not need to use elemental diet for pancreatitis. Another myth that exists is that vitamins and trace element deficiencies are rare in current day practice and they are academic curiosities. No, not so at all. They are common but not recognized. Obese patients are also micronutrient deficient and you must recognize and treat. Routine lab testing is not used, and whether you use enteral or parenteral nutrition, you have to think about micronutrients as an integral part of therapy. And this was a position paper that was published just recently with an international group. I was proud to be one of the authors, where the routine addition of micronutrients to parenteral nutrition, although strongly recommended, is not always followed. So it is delayed. And in certain conditions, additional doses may be needed. This was an expert opinion group that said that physicians and dietitians must be made accountable for not using parenteral nutrition micronutrients. And we have to sensitize clinicians regarding the role of micronutrients as an integral part of nutrition therapy. There's another myth that goes on saying immune enhancing formulas are better. And immune formulas have taken a beating over the last few years, even though the definition of immune enhancing formulas itself is a little bit vague. Now, in the preoperative preparation of the patient, because there is no big difference between immune nutrition and standard nutrition, standard nutritional support, standard oral nutrition supplements are less expensive, widely available. And this meta-analysis by Hegazi and colleagues clearly states because that the cost is less and the accessibility is better, in the preoperative preparation of patients, routine use of standard oral nutrition supplements are as good as using immune enhancing formulas. Another myth that exists is that parenteral lipids cause fungal infections. Well, in parenteral nutrition, when lipids are used, the fungal infections occur because of a high glucose level and the presence of a central venous catheter, not because of the lipid emulsions. And this is a paper co-authored by me and Dr. McGee, clearly shows the evidence to show that lipids do not cause fungal infections. Another myth that exists in many Asian countries is that blenderized kitchen-prepared diets are safe and cheap. Nothing is further than the truth. If you use blenderized kitchen-prepared diets, especially in the intensive care unit, in the year 2020, 2021, it is wrong because the nutritional content is unknown. The dietitian may think that the blenderized kitchen-prepared diet has the appropriate calories and protein, but nothing is further from the truth. There's a huge variation. Osmolality is not known, lactose is present, microbial quality is so poor in blenderized kitchen-prepared diets that the patient suffers from various gastrointestinal and systemic complications. The viscosity is high, requiring large bore tubes, and it is difficult to make calorically dense. And if you take the cost of procurement of ingredients, storage, cooking, handling, transport, wastage, then kitchen-prepared diets are actually more expensive to the hospital and to patients. So my concluding remarks are that we need to forget the myths of enteral feeding in the critically ill patient and provide optimal nutrition support to sick patients. Thank you very much.